Okay, so you heard from Mark already about technique. What I want to talk to you about today is sort of how to think and sort of philosophical thoughts that I have developed over the last few years in terms of fat grafting. The goal is to really see the face differently. And if you start with Sharon Stone in her 20s to her 40s, and you look at that evolution of change, it looks very much like she's got extra skin on the upper eyelids, that her brows are falling, and there's a huge gravitational component. But if you go and really look at those brows, there isn't a significant component of descent. The eyelid on the right has descended a little bit, but the one on the left is actually retracted up a little bit. So net gain and loss is very minimal when it comes to descent. But if you look carefully, there's that orbital rim that's exposed. And so there's a lot more volumetric collapse of the face over 20 years than there is gravity in general. And if you take a narrower time frame from early to late 30s, you can see that what obviously looks like dermatochalasis, brow ptosis, may be actually more of volume deflation and more exposed to the orbital rim. And if you look very carefully around the eyes, the cheeks, and the jawline. So what we try to do is communicate to a patient, because a lot of people say, well, my patients would never buy fat, they don't get it. Well, that's because you're not communicating it well enough. It's your job to make sure they understand it. So why am I doing so much more fat? Better. So my goal for you today is to understand how to communicate it better to someone. So I use a paradigm, I always use analogies to help people understand things. So I look at it like a glass of water emptying. So we're going to talk about that analogy after we understand if volume loss is basically from birth to death, is there a sweet spot in how you look? And if you ask women after 35 years of age, when did you think you looked the best? Oftentimes the response is 32, not 20. Because there's too much volume. And how much volume is there? Well, take a photo of a child at 1 year old, 5 years old, 10 years old, 15 years old, 20 years old, and just continue that. You're going to see a linear loss of fat from birth to death minus metabolic changes with weight gain. If you keep weight consistent, it's just volumetric loss of the face where it continues to involute inward. So if you're too full and you're ideal at a certain age, what is the goal of fat grafting? Well, the goal is to fill it to that ideal, depending on how old you are. The older you are, the emptier the glass is, and the more you need to fill. People always ask, this is permanent. And I use an analogy you'll hear later on of hair restoration, because when hair transplants are placed in, the blood supply is great, the graft is permanent, but you're going to lose surrounding native hair. Same thing with fat. The fat is permanent, but at the same time, overall, over time, you're going to start losing your native fat, and you're going to continue to age. It doesn't stop the aging process, but you're going to see in this twin model in a moment that actually, even years down the road, you still look so significantly younger than your twin. So we have to think about artistry in a way. It's important to be artistic in what we do and to see faces differently. First, we have to understand what the evolution of facial shape is as we age to understand what kind of artistic application can we apply. So when we start, as we said, very young, there's a lot of roundness to the face in a child, and that continues into the teenage years, and it still actually continues even into the early 20s. There's this very full, round attribute to the face, which may look attractive when you look at another face, but a lot of times when women, you ask them if they like that look, they'll say, no, I don't want that on my face, because I remember when it was too full. It's very interesting how we have that different perception. You start to lose that volume in the lower face, and you start to narrow out and start to triangulate the face. And so you continue into your late 20s with more predominance of the triangulation and less of that circular shape. And we continue into the early to mid-30s, there's even more buccal hollow, and that buccal hollowing gives sometimes a sculpted look that some women like. As you continue, though, you get actually starting to look slightly more masculine, late 30s, early 30s, when there's a flattening effect to the upper face, and the predominance of the lower face, either due to maybe slight gravity, maybe not, maybe some involutional changes that occur around the jawline, maybe some weight gain, those components that start to square off the face and make it look less feminine or attractive. I always say that both men and women become more masculine as we age, and so the goal for men is slightly a little bit more complicated when you're talking about rejuvenation. And so as you continue, you start to have lower facial dominance. So the upper face starts to hollow out with weight being consistent. And you continue to have more dominance in the lower face where you can almost look cadaveric as you proceed further and further down. So, blepharectomies or excisional techniques around the eyes, in my opinion, should be more conservative in nature just to sort of limit these issues. So it's about inverting that face back to a heart-shaped face. But what I like to think about is more of a refined concept, which is the fact that the buccal transition going down into the lower face is sort of a joining zone. You heard from Mark about highlights. I think that the buccal area, if it's over-exaggerated, can either make the cheek look too cheeky, or the idea that the transitions going to the lower face look too disjointed. So a huge component, what I like to do is when I'm working on a face, is to shape it in such a way that the transitions are very non-existent, if you will, and what's more prevalent are highlights. So the way that we read a face, and the way that we really read a face is with top-down lighting. That's what the world we live in. If we're at the beach or we're indoors and under fluorescent light, it's how we exaggerate those shadows. So I don't use flash photography when I take my photos. I just take a small room with bright lights on top going down to show you what how we actually see each other normally. So how do you design an oval? Well, each face is different. If you look at this lady, I did do a rhinoplasty for her, but in addition, what you're seeing is, and it looks like the lighting is different, but it is the same camera in the same room in this situation. What I've done is I've really looked at the fact that the face is wide and heavy on the outer portion. So what I didn't want to do is exaggerate the buccal area, so I didn't put anything in the buccal area. I just put a little bit more toward the center cheek, a little less to the outer cheek, to sort of draw the face forward and make that face look a little bit more linear going forward instead of exaggerate some of the width to it. This face here, you can see also with Asian faces, they tend to be a little bit heavier on the lower aspect, but there's a little bit of buccal hollow that's just starting. So my goal for here is to be more conservative with that transition, but still to create more of a nice oval shape to the face. So I put a little bit into the buccal area, and again, very conservative to the outer lateral cheek when I'm working on an Asian or in someone that has sort of a larger, rounder face. This is a lady here that, if you see, there's more global hollowing. The buccal zone, to me, needs a little bit more filling. It helps me transition the mid-face down to the lower face a little bit better. Of course, I did put some in the brows, I did put some in the lower eyelids, and I did put some under the chin area. And what you're seeing here is a little bit more, not aggressive, but just a slight more in terms of artistic attribution into the buccal area, and then a little bit more to the lateral cheek to create that blending. And when I work on the outer cheek, what I'm looking at is where the zygoma goes over, and I just want it to blend nicely down into the buccal zone. And this lady here, same thing, conservatively, you see it's a little bit more hollow toward the outer aspect, so I blend a little bit to the buccal zone and blend it down. And what you're seeing here with a little division, the two numbers there in the buccal area, is that some of it is mainly in the central buccal, and then that area where the bone inflects downward, I put a little bit out there. And that 1.3 on the lateral cheek area, right here, is also feathered downward, so that transition of the bone is not exaggerated, but that shadow below it is blended in. All these photos are at least a year out after fat grafting. These are single session treatments, by the way. The only other thing they did was Botox. So what you're seeing here is, in my opinion, more buccal deflation, where the face is very narrow, it's very linear and long. So to create that little bit subtle ovalization of the face that's softer, more feminine, it needs a little bit more attention to the buccal area and a little bit more widening to the outer subzygomatic region, so that you can create that blending effect that's going down. So the one here, that new number that you're seeing, is what I call medial buccal hollow, where you start to have either loss of dentition, late 50s, 60s, and just that little bit of flattening effect you're seeing more medially. So I sort of divide the buccal zone into a central component, and then sort of the area farther back, which to me is a critical zone, and then the last toward the medial aspect. This is, as you see, I think the principal culprit right here is not, yes, periorbital hollow, but you're getting a lot of the subzygomatic region over here that's really tapering off, causing this very cadaveric hollowing that goes on the outside. So for me, in this situation, what I want to do is really focus laterally and provide that blending that goes down, so that the whole outer aspect of the cheek articulates less down with the buccal area, and there's a little bit more of a softer, gentler stroke from cheek down at the buccal area. And the reason these photos are taken from the frontal view, they're harder to conceptualize volume from a frontal view, but that's how we read faces. When we're talking about ovalization, we're talking about how we read beauty, attractiveness. It's about head-on perspectives. This is, again, you can see how important the buccal zone is by really filling it. To me, it's sort of the center and also the lateral component, sort of at a mix. And that 4 you're seeing is actually more sort of center feathered laterally. So it's obviously it's not exactly in one locus, but it's just sort of arched out further out. And then a little bit toward some loss of dentition sort of medially is where I go as well. This lady here, this is of course, as I said, with neurotoxin as well, but you can see that it's really, if you just give her a nice cheek and you don't think about the buccal zone, you're really missing the picture in terms of global rejuvenation. And so again, focusing really centrally, a little bit feathering out to the sides and creating a little bit more blending in that area. So you heard longevity. How long does fat last? Does it last a day, or does it last 3 months? Does it last a year? It's permanent. If the fat takes, it's permanent. My mom is over 4 years out, and she looks just as good, if not better actually, in some respects than she did even a couple years ago. But how long does it last? Why, when I was studying for my hair boards, I started to really understand that fat is a graft. So why would it walk up and leave at 3 years? Would you have a skin graft you put on the arm, all of a sudden just disappear in 3 years? People say, oh, fat lasts 2 years. How do you say that? The fat is either going to die or it's going to live. There is no other in between the two. It's a graft. This is not Restylane. It has blood supply or not. So when I started to understand how hair developed over time, you would see hair go through different processes of a free graft. And over a period of about 6 months to a year, the graft would start to neovascularize, have new blood supply. And I would see these patients a year to two. I had one lady from Taiwan, I didn't see her for like a year and a half, at 2 years, didn't gain weight. I asked her exact same weight. She just looked 10 times better. And there's a vascularization of the graft. Not everyone gets this. Sometimes the fat is not perfect in its take, but in general, you can see improvement. So what I see is gross swelling, and sometimes at a month it's almost artificially good because it stretches every wrinkle and pore out. And then it goes through a period of time, somewhere between 3 months to 9 months, where it may not look as good, and that's when a lot of doctors give up. They go, oh, it didn't work. I saw him at 3 months. It's a joke. Well, do you look at your rhinoplasty results at 3 months and go, that's the end of it? No. Do you look at your facelift results at 3 months and say that's the end of it? No. Well, why should you do that with fat? Because fat is going through a quiescent period where it starts to revascularize and starts to vascularize and get better. Minus further aging, you know that glass of water analogy where it starts to go down, you have to look at your long-term photos. So I encourage you, for all your patients, just like with urinoplasty patients, you're taking those photos, take the photos of your fat and watch them over time. If you don't do that, you don't have feedback to understand how much fat to put in to get what kind of results. With the question of PRP, do I do that? No, because I get generally good take. And if I add any more, I think the fat will be too much. You don't want a fat face, you want a face that looks elegant. So let's go through a year or a year and a half with the lady with, again, the only thing I did was neurotoxin for her, nothing else. And if you look at her about a week, it's puffy, it's bruised, it's swollen, it's not quite good. And then at about, a month out, still a little full, and it looks good. And then about 3 months, maybe that looks better, maybe it doesn't look as good, doesn't matter, it's just about, a change in the face that's going down. 6 months, maybe it's gone down more. Maybe you're thinking it's going to disappear now, so it's going to be a trajectory going toward loss. And I've got many of these photos on my website if you want to look at them. 11 months, it's starting to improve. And at 15 months, you can see she has a softer look to her, now 50 versus 48. And the only thing else I did was Botox for her, nothing else, and very standardized all the way through. So donor dominance, this is the concept extrapolating from hair. People that do hair restoration understand this, which means if I take hair from the donor area and move it to the front, it will behave like the hair on the back of the head. Well, that's the same thing with fat. So what is the biggest risk with fat? Is it lumps and bumps around the eyes? I don't believe so. If you're doing controlled work, careful work, not over excessive work, you're going to get consistently reliable, good results. What is the fear that I have, that I convey to my patients before I start? It's weight gain. If you think about the donor characteristics of fat taken from the belly and thighs, it's very prone to weight gain, and it's very resistant to weight loss. I've had patients lose 10, 15 pounds, and they still look pretty good. My mom's lost 15 pounds since her procedure, still looks to me excellent. But when people start gaining 20 or 30 pounds, there's more risk. So I always want to remember that and be careful when you're dealing with people at a very young age, and you're trying to place fat into someone 20 before metabolic changes, before pregnancy. You want to be a little bit more careful when you're doing this. Fat is not Restylane, it is a graft. So again, if you're doing careful work, what I'm not worried about so much is lumps and bumps. What I'm worried about is patient compliance toward weight maintenance, and especially in Texas. That's where obesity is the king. So you heard me mention briefly, like with hair restoration, I am using PRP. I'm doing my first case in a week from now because I've seen the studies. I think that early PRP, maybe mixed with A-cell and other things out there, could potentially increase growth. I want more hair than I can get. You're not going to complain I put too little hair up here. You're not going to complain I put too much hair up here. You're going to complain I put too little hair up here. Whereas with fat, it's not the case. You put too much fat in, it's not necessarily good. So I don't think I want any better take than I have right now. At least that's my opinion. You can ask 10 people, you get 10 different opinions. Implants versus fat. When do you use an implant? You've heard some really good talks about implants this morning. What is my philosophy? I really believe like for like, replacing like for like. What does that mean? So remember, to me, I think the principal mechanism of aging is fat loss over time. You do lose some bone, but I think with good dentition nowadays, it's not a major component as soft tissue loss. So there's a disproportionate amount of soft tissue loss compared to hard tissue loss as we age. And if that's the case, we're going to start exposing hard tissue below. And what we don't want to do is put an implant in and exacerbate that relationship where you're actually getting more exposure of underlying hard architecture. So what would be more ideal perhaps is to go back and increase that using fat transfers so that you actually soften the transitions and increase the padding and the soft tissue envelope. This is a good example of bone exposure we started with. So what I believe is with implants, I think you expose transitions. I've obviously done certain implants you're okay with, and with fat grafting, I think you decrease it. That's it. Thank you for your attention. That's my email if you need to reach me. Okay.